Hey guys, Marshall with PhysioU. I'm here with two DPT students, Chris and Cameron. Thanks for joining us, guys. And today we're here at the teaching table where we try to bring the classroom to the clinic. And today our topic is patient education. All right. Something that's very important in PT, something that can be initiated very early on in your eval, or something that people tend to hold off to the end. Kind of where you put it on kind of depends. But the big picture is when we are educating patients, we want to try to hit a couple of key points, right? We want to kind of get them to understand like what's going on, right? A lot of times they come to us for answers, and if we can give them an answer, automatically it decreases some of the fear, right? We want to kind of be able to tell them why it's going on, right? Be able to identify like, hey, the reason why you hurt is because of this. We can change that. What we're going to do to help them. So what we're going to do in PT, our treatment, right? One of the hardest ones to answer is the duration. Like, how long is this going to take, right? We can use tissue healing time, right? So how long does it take for a bone to heal? How long does it take for a ligament, for a muscle? However, we know that also pain doesn't necessarily always follow tissue healing time. So as far as how long does it take for the tissue to improve? All right, hey, here's enough. How long until your pain goes away? That's always a harder answer to question. It's a harder question to answer. And then lastly, which kind of leads into the treatment-wise, but also like what are some things they can do to help themselves either decrease stresses on the tissue or improve the impairment even better, like more of an education on education, right? Think about it. But with that kind of overview, let's take some questions.
Yeah, so my first question is really being smooth with this education process of educating the patient. So I find I do all this objective testing, because the patient's not as irritable, yet after the testing, they're flared up. So how can I best manage my time instead of flaring them up and then say, oh, can you sit up for me? Let me tell you what's going on.
I think, so going into the objective, you hopefully had an idea of what the irritability already was. And sometimes we say, oh, it's low, and then by the end we realize, man, maybe it was higher than it was. So I think the checking in throughout, right? So every couple of tests, it's like, hey, making sure, hey, are you back to your baseline? Are you back to your zero? So you don't just necessarily have the beginning and the end. Right? There's little things in between where you can assess, hey, flip over on your stomach. Now that you're prone, hey, how you doing, right? Are you kind of back to your zero? Or are you back to your one, whatever it may have been? Those don't take any time, right? It takes 5 seconds. So I think that's part of it. And then at the end, if you did flare them up, right, I always kind of apologize, right? I tell them, sorry about making your pain worse. Sometimes it's part of the process to kind of figure out what's best, how best we can help you. And a lot of times if you just kind of apologize and that they understand, right? When patients go to the dentist, they understand sometimes it hurts when they're in your teeth, but it's for good reason. So they understand that idea behind it. Getting the flu shot, it hurts, but they understand, hey, it's going to help protect me a little bit. So I think educating them that, hey, this is why you are that way. However, this is what we can do to decrease it. And so then you show them, you prove it to them, right? You made their pain worse. Can you make their pain better?
In the clinic, I ran into quite a few patients who maybe had external factors in their life, say stress. They were taking care of a loved one that really manifests itself in physical pain. And it is kind of being a student, it is kind of sometimes hard to have those difficult conversations and educating, that these factors might be contributing to the pain that they're having. So how do you go best having those tough conversations?
Yeah. I'd say you're right, those can be tough conversations, and I'd say it's different than maybe your musculoskeletal typical PT one where we're telling them, hey, this is what your diagnosis is because of this test. This is what we're going to treat because when we tested it, it was weak or it was short. That's kind of very one-to-one, right? Yeah. But for patients where we're treating maybe more the psychosocial factors associated with pain, it's nice to make sure you have their perspective and their beliefs a little bit before you start telling them yours. So hopefully they've kind of already mentioned that stress makes it worse, right? So and if they haven't, I may say, hey, do you feel like stress plays a part in your pain at all? Have you noticed a change in your pain levels based on whether you're stressed at work or not stressed on the weekends? So you kind of try to add in little questions, and hopefully if they're answering yes, then it's not necessarily you telling them that stress makes it worse. It's, they told you that stress makes it worse. It's like, okay, so then now you get to play the idea of this is why it makes it worse, right? right? You're the educator. You're the person that has went through school and you know the answers. But hey, when we're stressed, it makes our nervous system, right, more hypersensitive. It changes chemical neurotransmitters that can make us more irritable. And you use analogies. It's like putting gasoline on a fire, right? It kind of flares things up, even though there's no more damage to the tissue. So it changes the idea of like, all right, well, what do you do for stress management versus, hey, we need to stretch your quads, or we need to work on prone press-ups for your back. It's like, oh, maybe we need to manage the gasoline before we try to do the fire part. The small fire, gasoline's making it bigger. Let's work on that. And then you start to realize that they're not doing anything for stress management. So, all right, let's talk about some of the big pillars. Are you sleeping? That helps with stress. Are you practicing mindfulness or meditation? That helps with stress. Are you doing aerobic activity, exercise? Are you getting your heart rate up? Are you sweaty? Right? Our brain is a big medicine cabinet waiting to let loose if we tap into it a little bit. So you can kind of start educating on those, which is very different than the idea of, hey, we need to work on stretching and strengthening. It's like, think big picture. And I tell them, hey, we can't help you with your knee pain if there's this big looming giant that's kind of driving everything, right? We need to take care of this big giant, and your knee pain will probably get better a lot quicker and easier if we can take care of that first. So, yeah, I think that's a good question.
So I have a scenario. So I had this runner. She was primarily a weekend warrior.
Yep.
Running a lot, 8 to 10 miles per day on the weekend. So Saturday and Sunday. And my thing with her is I felt like I struggled with the education part because I knew the MCL was tender. I knew the validated stress test was positive.
Okay.
I knew she had weak glutes, so I provided glute strengthening. The thing was she kept coming back, slightly better, maybe 10% better, 15% better, 20% better. And I just really needed help with how do I sell this to the person that this is what they need if they're going to continue to do what they do.
And was there did she believe that the strengthening would make her better?
I think she was kind of confused on that. I think that was partly my fault there. Okay. And I just didn't really know how to really tell her and get her to understand that that was causing her knee pain.
Okay. So I think if we use that example, like specifically, right, we know that the MCL is stressed with that valgus. I would maybe almost make her go into valgus and do something like do a single limb squat, do something pretty hard where her knee dives in, and it hurts, right? Kind of prove it, right? Hey, it hurts. Correct it. Pull her knee out. Do it again, right? That corrective test, and it feels better. Like, hey, you know what muscle helps keep your knee from falling in? Right? That's your glute med, right? Maybe you put a big piece of like a leukotape on that MCL to stabilize it, right? And say, you know what? Now retest it. Does that change how you feel? And it feels better. It's like, you know what muscle helps do the same as that tape, right? Get your glute med stronger. So that'd be part one, is just prove to her that this movement, because sometimes it's hard, like my pain's here, why are we working way up here, right? They don't necessarily get that. But if we can prove to them that, hey, if we can change it, like that's part one, it feels better. The thing that changes that, so you have to make the connections for them. The thing that changes it is this, right? So I think that's one part of it. The second part of it is I'll use research. Right? I'll say, hey, we MMT your glutes. How old did you say she was?
She was 32.
Okay, so she should be able to have a glute med, right, of like 40 pounds if we're testing proximal, at least 25 pounds for testing distal with a handheld abdominal. I'll test your glute meds and I'll compare it to the other side and say these should be equal if they're not. Or I'll say you should be this strong, and if you can't, how do you expect your knee to have good alignment and less stress if you can't hold this? You kind of like almost, especially as a big run, you kind of make it a little competitive. Like, hey, this is what norm is. This is what you are. Running's not going to make that normal. Do you know what will make that normal? Right? This exercise. So I think there's a couple of things where you can motivate patients once they've bought in and they understand it to then continue to do it more. And I think, let's say there is someone who totally gets it, same scenario, but she's doing her exercise every single day, right? And she's getting stronger, but when she runs, it still hurts. You might need to have a conversation with her about shutting it down, right? It's like, hey, you know what? You're trying to heal this and trying to help make it better, but you keep just taking it away, right? It's like building, like using a deck of cards, you keep building them up, or Jenga, and you just keep taking one away. Eventually it falls, and you start building it up, and you take one away. And you might have that conversation like, hey, it's not going to get better in an efficient manner unless you just stop running, right? You're running on empty and you can't fill it up. Does that kind of answer that a little bit?
Yeah, that was awesome.
Do you have another question or
No, you answered it. Yeah.
Okay. Let's see. I think based on here, did we kind of catch things? I think one of the important things that we sometimes miss is this self-help one, right? So we can talk about with our patient education. We say, hey, you need to stretch your ankle, right? You need to stretch that ankle, and they go and they stretch 4 or 5 times for 30 seconds. There's your 2.5 minutes. And then they go and spend the next 20 hours in plantar flexion. So they're sleeping on their stomach in plantar flexion. They're sitting in their car in plantar flexion, sitting in the office on the couch with their feet out in plantar. Really, are you going to make a big change in dorsiflexion if you're spending everything else in the other direction? So it's like, all right, hey, you have your exercise, but also when you sit or when you sleep, the other things, can you put yourself in a position that's more optimal to help that impairment get better quicker, right? And I think that's a big thing we kind of miss sometimes with others. We tend to be good with the spine, right? We give people these exercises for extension. We tell them, hey, don't sit slouched, use your tower roll. So we're sometimes good with that stuff, but maybe not with our peripheral joints where we're, hey, that MCL girl, don't let your knee keep diving in, strengthen. And then she goes and she sits with her knee dived in for 8 hours, right? It's like, well, can we educate patients better? But another key point I want to talk about is like, how do we make it less threatening? So it kind of goes into the idea of stress. But if I tell you that, hey, you have a bulging disc and it's herniating out the backside, and every time you bend over, it pushes that disc. Like, that's pretty scary for patients. Versus, hey, we have discs in our spine. Sometimes they get irritated. They can become stressed. When we bend over, it adds stress to them. So we need to kind of maybe let some of that stress come down, let the tissue become more durable, become more strong, it heals, and then you can kind of bend over like you're supposed to, right? Bending is totally a normal thing to do. Otherwise, for the rest of their life, they don't ever want to bend over because they have this thought virus in their mind. So how do we kind of gently tell them what they think is going on, right? Because they do value being told what's going on. They want to know what's going on, but not necessarily in a way that's going to scare them and make their pain worse. Right? And people don't really care how much you know until they care that you know, right? So that's kind of a common thing I always try to keep. When I treat patients is like, hey, I want them to know that I do care for them. It's not necessarily about how smart I come off and I know all the answers. It's hey, our first thing is just, I'm sorry you're in pain and I hope you get better and we'll work together to figure out a way. But it's that fine line. We do want to come off educated, right? They did a survey and a study that looked at what patients value in PTs, and one of the things is education and knowledge, right? So you don't want to be like, oh yeah, you're back. Yeah, stuff going on there. We'll help it. Use some stuff. Be educated, but not arrogant, right? That's that line. Another key point is not too much at once, right? Another article said that patients only remember 30% of what we say. So all these things I just said to you guys, you're going to walk away with hopefully 30% of it, right? How do we know what they walked away with? Right? We can have them teach back to us. So a lot of times we'll be like, all right, so I know that was a lot. What do you, in your words, what do you think's going on? Right? Can they tell me what they're doing? And now show me, let's go from there, show me what you're going to do. What are you going to do differently? Right? Not me telling them where they can answer, yes, I get it, yes, I understand, yes. They have to actually teach it back to me. Right? Good. I think that kind of handles some points of patient education. We could spend much more time on patient education, but thanks for hanging out. Follow us at PhysioU.com or our social media. Also, we have a great patient education app. If you go to PhysioU.com, it actually has all the education for each common condition and some of the key common points. Yeah, take a look. Thanks, guys. See you next time.